So hi friends, today we are here to discuss the NEET PG, NEET whatever the grant test 4 and we are going to discuss the questions which were asked in the subject of surgery. Okay, so let's start by talking about them. So what you need to understand is that the first question was that which fluid should not be given to the patients with a head injury. Now what do you think, like what is the basic problem in the head injury? The basic problem in the head injury is because of the what you call as a head, like there is an increase in the intracranial pressure. There is an increase in the intracranial pressure. And why is this particular intracranial pressure kind of increasing? Because of the cerebral swelling. Okay, cerebral swelling, or rather edema. You understand my point? So in other words, this particular question is trying to ask you that which of these particular IV fluids is going to increase the interstitial component. Okay, so it is going to kind of increase the tissue edema. It is going to increase the water which is going to go in the intracellular and the intercellular space. Okay, so the answer to this particular question is no doubt it is a 5% dextrose. 5% dextrose consists of just water plus dextrose. Now, if at all this particular, like in this 5% dextrose, once you kind of give it, what's going to happen? The dextrose will be utilized by the body, and all that is going to be remaining is a free fluid without any solutes into it. So what is going to happen? This particular fluid is going to enter into the interstitial space and the intracellular space. That is going to increase the tissue edema, and that is the reason why 5% dextrose is not given to the patients with a head injury. So that is what you need to understand over here. Now the next question which they ask you is that the patient develops a lesion 6 months after the surgery. Okay, the diagnosis of this condition, analyzing the image. Okay, so what is the kind of in this particular image, what is this particular image trying to show you? This particular image is trying to show you that the patient is basically suffering from a keloid. Now what is this keloid? Keloid is basically the like a condition where there is an abnormality of the scar maturation. So there is an abnormal scar maturation which takes place. Okay, so what can happen is that it can lead to either a keloid or it can lead to an hypertrophic scar. Why is it a keloid? Because I hope you're able to understand here. What you need to understand is that this particular scar is growing beyond the boundary. Okay, beyond the boundary of that this particular abnormality of the scar is basically grown beyond its kind of boundary, and that is why this particular thing is a keloid. Okay, so this is not a hypertrophic scar. You need to appreciate how do you distinguish the hypertrophic scar from the keloid. Now another important thing which you should know about the keloid is that what is the most common location? Okay, what is the most common location? So this is an important thing which you should know. So like the books basically describe it that it, like if you join the like both the shoulders and the sternum together, the triangular area which is basically formed in between this, if at all there is a scar, the chances of hypertrophic scar in the keloid to form is much more. Okay, I hope you have understood. Now even in this particular figure you are able to see that this particular scar is basically present in the sternum, and that is what is the most common. Okay, so this is what is the most common, what you call as the most common location for the formation of a keloid. Okay, sternum. Okay, I hope you are able to appreciate this. So this is what is the most common location for the development of a keloid and the hypertrophic scar. Now what is the most likely cause of this particular ulcer? So what is this? Okay, can you please tell me what is the answer? The answer to this particular question is venous ulcer. Now I hope you are able to appreciate. Just look at this particular ulcer. Where is it occurring? This is basically occurring on the medial side of the leg. Okay, where is it occurring? It is basically occurring on the medial aspect of the leg in the lower 1/3. Okay, so medial aspect of the medial aspect of the leg, lower 1/3. Okay, so this is what is a characteristic location of a venous ulcer. What is this particular area known as? This particular area is known as Gator's area. This is also important, Gator's area. Okay, so this is what is a Gator's area, and this is a very important thing over here. Whatever the ulcer is going to happen, this is what is a venous ulcer. Medial aspect of the leg, lower 1/3, Gator's area, the ulcer is venous ulcer. What about the arterial ulcer? Where do you kind of find this particular arterial ulcer? Arterial ulcer is basically found on the lateral aspect of the leg. Okay, lateral aspect of the what you call as the foot rather. Okay, so it's not really the leg, it is basically the lateral aspect of the foot. And okay, so I'll just kind of change it. It is on the lateral aspect of the foot, and tip of the fingers, and tip of the fingers. If at all there is an ulcers which is basically happening on the lateral aspect of the foot and the tip of the fingers, this is what is an arterial ulcer. I hope you are able to appreciate this particular point. Neuropathic ulcers, they usually occur at the pressure points, and the pressure points. Okay, so this is again important. Now, very recently there was an exam in which they had kind of shown a very deep ulcer at the heel. And what was that? That was basically a neuropathic ulcer. So that is what you need to understand over here. Tuberculous ulcer can occur at any places, but in the cervical region it is kind of common. Now, another important things which you need to understand about these is the edges. Okay, so edges of the ulcer. What about the venous ulcer? So the venous ulcer is the one which is having the sloping edges. What about the what you call as an arterial ulcer? Arterial and the syphilitic ulcer. Syphilitic ulcers, these are the ones which are having the punched out edges. Okay, so they are the ones which are having the punched out edges. Then what do you have? You have what you call as tuberculous ulcer. Tuberculous ulcer is the one which is having an undermined edges. Okay, so undermined edges are basically seen in your tuberculous ulcer. Okay, so tuberculous ulcer, undermined edges. Okay, then we have a basal cell carcinoma. These are the ones which are going to have a rolled out edges. Okay, so rolled out edges are going to be seen in your basal cell carcinoma, and the squamous cell carcinomas are the one which are going to have an everted edges. Okay, everted edges are the ones which are basically seen in the squamous cell carcinoma. So please try to appreciate this: squamous cell carcinoma, venous ulcers, arterial syphilitic ulcers, tuberculous ulcer, and the basal cell carcinoma. Very important. Even the edges are very important. N number of times the questions have been asked over this, so you need to appreciate and you need to understand this. Okay, now there's a patient in the post surgery develops a low grade fever on the day 5. There's a pain in the calf with the pedal edema. What is the most likely diagnosis of this particular patient? The answer over here is a deep venous thrombosis. Okay, so what is this? This is a deep venous thrombosis. Now here, what they have given you, the post surgery. Post surgery basically means that the patient was immobilized. And because of the immobilization, what happens? There was a venous stasis. What happened? There was a venous stasis. And because of the venous stasis, what is going to happen? The blood is going to get collected, and over a period of time, there can be what you call as a thrombosis. And this will lead to the fever. Okay, so there is going to be the post-operative fever. So deep venous thrombosis is one of the causes of a post-operative fever. And over here, the characteristic scenario which they had kind of given you, that there is a patient post-surgery, low-grade fever, post-op day 5, pain in the calf and the pedal edema. What is the diagnosis? The answer over here is a deep venous thrombosis. Okay, I hope you have understood this particular point. Very important. Okay, now there is a what you call as a 25-year-old patient who was brought to the emergency room after the road traffic accident. The respiratory rate is 25 per minute. The blood pressure is 80 by 45 millimeters of mercury. On examination, there is a hyperresonance heard on the right side of the chest. The chest X-ray has been performed, which has been shown below. What is an appropriate management in this particular case? Okay, so just look at this. Let's look at this particular image. What are you able to find? I hope you're able to appreciate that here there is a collapsed lung. What is this? This is what is a collapsed lung, and I hope you're able to appreciate that this part of the lung is more black. Okay, what is it? This is more black as compared to the opposite side. Okay, this is more black as compared to the opposite side, which basically gives you the diagnosis of a pneumothorax. Okay, what does this give you? This gives you a diagnosis of a pneumothorax. What is a pneumothorax? Pneumothorax is a condition where there is air inside the thoracic cavity. Okay, so what is a pneumothorax? Pneumothorax is a condition where there is an air which is basically present inside the thoracic cavity. Now over here, if you are able to appreciate that the blood pressure of the patient is 80 by 45 millimeters of mercury, this means that the patients are unstable. Okay, so what is there? The patients are unstable. So if at all there is a patient who is having a pneumothorax and the patient is unstable, what do you think of? That the patient is basically suffering from a tension pneumothorax. So I hope you are able to appreciate that the pneumothorax can be of two types. There can be either a simple pneumothorax or there can be a tension pneumothorax. And in this particular clinical scenario, I hope you are able to appreciate that the diagnosis of this particular patient is a tension pneumothorax. What is the diagnosis? It is a tension pneumothorax. Okay. Now, whenever there is a patient of a tension pneumothorax, what is the management of this particular patient? The management of this particular patient is that there is a wide bore needle insertion in the 5th intercostal space. That is what you need to do. Yeah, followed by the intercostal drain in the fifth intercostal space. So I'll just let you know what is the management of these particular patients. Okay, so what I'll do is I'll just let you know what is the management. So okay, I don't okay, just give me a minute. So how do you manage a patient of a tension pneumothorax? How do you manage a patient of a tension pneumothorax? So please try to understand, whenever you have a patient with a tension pneumothorax, there is something which is called as an emergency management, and there is something which is called as a definitive management. What about the emergency management? The emergency management can be what you call as what about the emergency management? Okay, so what about the emergency management? Emergency management is basically different for the children and for the adults. Okay, what about the children? In the children, the emergency management is that you have to put a wide bore needle in the second intercostal space in the mid clavicular line. Okay, and a wide bore needle in the second intercostal space in the mid clavicular line. This is what you have to kind of do in the children. What about the adults? In the adults, this has to be kind of given in the fifth intercostal space. Okay, so there has to be a wide bore needle. There has to be wide bore needle in the fifth intercostal space in the mid axillary line. Okay, so I hope you're able to understand. Wide bore needle in the second intercostal space in the mid clavicular line, wide bore needle in the fifth intercostal space in the mid axillary line. What about the definitive management? The definitive management is that you have to kind of go ahead and what you have to perform is a ICD placement. Okay, you have to perform an ICD, and this has to be done in the fifth intercostal space in the mid axillary line. Okay, I hope you are able to understand this particular point. Very important. This is how you manage the patients of a tension pneumothorax. So over here, the answer is definitely going to be the B, wide bore needle insertion in the fifth intercostal space in the mid axillary line, followed by the intercostal drainage in the fifth intercostal space. Okay, so that is how you have to manage these particular patients in this particular manner. Now, identify the type of the shock in the patient who has had a profuse bleeding and has a central venous pressure of less than 5 millimeters of centimeters of water. So what does it tell you? That the patient is having profuse bleeding. It means that the patient is basically in the state of hypovolumia. Okay, now over here, obviously it is going to be a hypovolumic shock, as you can understand over this. Okay, so this is a pretty simple question. Here has to be a hypovolumic shock. Now let's kind of talk about this. So in the cardiogenic shock, what is going to happen? The blood in the body is going to be normal. It's not going to kind of, in the cardiogenic shock, there's no loss of the blood. But in the cardiogenic shock, what is going to happen? This central venous pressure is going to be elevated. In the neurogenic shock, what is going to happen? Everything will be low. So even the central venous pressure will be low, but the the bleeding is not going to be a part of your neurogenic shock. Same with the anaphylactic shock. What is going to happen? Then the central venous pressure will be low, but the bleeding is not going to be a part of it. Okay, so I understand it's a not a very kind of complete question, but whatever the information has been given in this particular question, it is decent enough to tell you that, you know what, you are dealing with the patients of a hypovolumic shock. Now, what is the learning point out of this? The learning point out of this is that you need to appreciate the difference. Like, how do you distinguish between the cardiogenic shock, hypovolemic shock, neurogenic shock, and anaphylactic shock? So just kind of go through it. That's important for you guys. Very important. Okay, so based on the heart rate, based on the cardiac output, based on the total peripheral resistance, based on the cold, clammy extremities, based on the central venous pressure, all these particular parameters you have to take into consideration in order to distinguish between all these different types of the shocks. Okay, now a 50-year-old female presented with a sudden onset headache. She describes this as the worst headache of her life. The CT scan has been shown below. Identified. So what are you? Okay, so even without this particular image, what you need to understand, you have a diagnosis of a subarachnoid hemorrhage over here. Okay, so why? Because here there is a female who is basically having a sudden onset headache. Okay, so sudden onset headache, that is what is called as a thunderclap headache. Okay, so what is this called as a thunderclap headache? What do you understand by the thunderclap headache? Thunderclap means that, okay, so let's say if at all I'm sitting over here and there is a lightning which happens. So what happens? Within a second I hear that gurgling sound, right? Over here also what happens in these particular patients, that the headache starts, and within a some time this particular headache basically goes to the maximum level. So that is what is referred to as a thunderclap headache. Okay, so I hope you are able to appreciate this particular point, guys. Okay, so that is what is the sudden onset headache or the thunderclap headache, and patients describe it as the worst headache of their life. Okay, so yeah, these two things are giving you the diagnosis of a subarachnoid hemorrhage. If you look at the image, you are able to appreciate that these particular areas are the places where the blood is basically present in the sulci and the gyri, and that is basically telling you that there's a blood in the subarachnoid kind of space, and that is why the diagnosis over here is a subarachnoid hemorrhage. Okay, so yeah, frankly, the image is there, that's fine, you can kind of use that, but it will be a bit difficult for you. But based on the history, yes, definitely you would have told that the diagnosis is a subarachnoid hemorrhage. Now, pressure sores are formed if at all the pressure basically rises above 30 millimeters of mercury. So what is this 30 millimeters of mercury? This 30 millimeters of mercury is referred to as your capillary closing pressure. What is this? This is what is your capillary closing pressure. And if at all the pressure basically rises above this, then you basically say that the patients are at a risk of development of a bed sore. Okay, so if at all the pressure rises above the 30 millimeters of mercury, that is when you say that the patients are basically having the, there is a risk of having this particular bed sore. So please remember this. What is the pressure? 30 millimeters of mercury, capillary closing pressure. Above this particular pressure, the risk of the bed sore definitely increases in these particular patients. Very, very important. Okay, now there's a patient with a road traffic accident brought to the emergency with the blood pressure of 80/60. The fast is positive. The fluid resuscitation was done. The patient was not improving. What is the next step in the management of this particular patient? The next step in the management of this particular patient is an exploratory laparotomy. Okay, so what do you need to understand about this? There is a road traffic accident. So there was an accident which happened, and the patient had a blood pressure of 80/60 millimeters of mercury. It means that the patient is hypotensive. Okay, so what is there? The patient is hypotensive. That's fine. Now the fast was done. Fast is positive. So what does fast tell you? Fast basically tells you that there is an increased intraperitoneal fluid. Okay, there is an increased intraperitoneal fluid, and if at all the fast is positive, this is an indirect indication that there is some significant intra-abdominal injury which has happened in this particular patient. And because there is some significant intra-abdominal injury which has happened, you have to kind of perform an exploratory laparotomy, because even after resuscitation, the hemodynamic status of this particular patient did not improve, and that is why what you have to perform is an exploratory laparotomy. You have to kind of open the abdomen, you have to explore the abdomen, and whatever the problem is there, you have to kind of repair that particular thing up. Okay, so I hope you are able to appreciate it. What is the diagnosis over here? Like, you have to kind of perform an exploratory laparotomy in these particular patients. Okay, I hope you have understood this point. Now, like given below are the few eye signs of the Graves' disease. Which of the following is kind of which of the following is a match? Okay, so what you need to understand over here is that this is what you refer to as your what you call as a eye signs. Okay, so what we have is we have a eye sign. So there are various eye signs which we have. So these are the eye signs which are involving the upper lid. Okay, so upper lid, you have to kind of go through these particular lists. This is very, very important. So Van Graffy sign, this is basically the lid lag on the down gaze. Del-Remke sign is basically a lid retraction. Stellwack sign is incomplete or the infrequent blinking. Groove sign is restriction to the pulling and retracted upper lip kind of lid. Then Boston sign is basically jerky movement on the lid on the down gaze. Gallenic sign is basically abnormal pigmentation of the upper lip, and Gifford sign is basically difficulty in everting of the upper lip. Okay, so all these particular things were asked to you. Gifford was asked, Boston was asked, Del-Remke was asked, and Von Graffy's is asked. Okay, so I hope you are able to understand this particular point. So as you can see, Von Graffy's is basically your lid lag on the down gaze. Then we have a Del-Remke is the kind of lid retraction. So yeah, all these particular things. The answer over here is B. Okay, so then what we have is Boston is basically your okay, so Gifford is basically difficulty in everting of the upper lid, and I hope you got the drill. Okay, so answer over here is B. That's all you need to understand. And these are the eye signs which are involving the upper lid. Now this is important for you guys. You have to kind of remember this. Just go through this. At least the important ones you have to remember. So even the Stellwack sign is important. Okay, infrequent blinking, that is again an important one. So please try to understand this. These are the important eye signs which are involving the upper lid. Okay, so this is what is happening in the Graves' disease. The thing which basically distinguishes the Graves' disease from the what you call as the other causes of a hyperthyroidism is that in the Graves' disease, along with the hyperthyroidism, you also get this ophthalmopathy and the dermopathy. But in the other hyperthyroidisms, you do not kind of get that. So this is how you this is what distinguishes the Graves' disease from the other kind of a causes of the what you call as a hyperthyroidism. Okay, so important one. Okay, now the burns management, which of the following is the fluid of choice? For the burns patients, what is the fluid of choice? What is the answer over here? So for the patients of the burns, the fluid of choice is your Ringer's lactate. Okay, so what you need, if at all nothing is mentioned to you, the fluid of choice is basically your Ringer's lactate. If at all they ask you fluid of choice for the burns in children. Okay, so if at all we're dealing with the children, what is the fluid of choice? This is what is your dextrose normal saline. Okay, so what we have is a dextrose normal saline. That is what is the fluid of choice for the burns in children. What about electric burns? In the electric burns, what you need to understand is that the fluid of choice in the electric burns is your normal saline. No, it's not like that you cannot use a Ringer's lactate in the electric burns. You can still use it, but the preferred fluid in the electric burns is your normal saline. But overall, in the flame burns, the fluid of choice is basically your Ringer's lactate. That's kind of important. Okay, now, why in the electric burns you have to use the normal saline, preferred to use the normal saline rather than the Ringer's lactate? Because in the Ringer's lactate, what you need to understand is that there is a potassium is also present, and if at all you kind of, and already in the electric burns there's a chance that the rhabdomyolysis would have taken place and the potassium would have kind of come into the bloodstream and everything, and if at all you use the Ringer's lactate, that potassium level is kind of going to increase even further. That might cause cardiac abnormalities and all those particular stuff. Okay, I hope you're able to understand this particular point. Important. Okay, I hope you have understood these particular points, right? Okay, Ringer's lactate, that is what is the fluid of choice for the burns. Okay, now how do you calculate how much amount of the fluid has to be given to these particular patients? So this is basically based on your Parkland's formula. Okay, so what is this? You have a Parkland's formula. Okay, so what do you have in this particular Parkland's formula? 4 into the total body surface area into the percentage of burns. Okay, so please try to understand 4 into total body surface area into the percentage of burns. This basically gives you the value x ml is basically given. Okay, and this, what you do is you divide this particular x by 2. So x by 2 has to be given in the first 8 hours. Okay, and the remaining x by 2 has to be given in the next 16 hours. Okay, so please try to understand. This is what is the Parkland's formula. 4 into the total body surface area into the percentage of the burns. This what is going to give you the value of x ml. X by 2 has to be given in the first 8 hours, and the remaining x by 2 has to be given in the next 16 hours. Okay, now this is based on the Parkland's formula. Now we have also come up with the recent ATLS formula. In the ATLS formula, what you need to understand, we have replaced this 4 by 2. Okay, so if at all the question specifically asks you how much is the fluid needed according to the latest ATLS guidelines, then you have to use the formula as 2 into the total body surface area burnt into the burns, percentage of burns. But if at all the question simply asks you or specifically asks you that, you know what, Parkland's formula ke hisab se kitna hai, then it has to be 4 into the total body surface area into the percentage of burns. Do not forget this particular formula. It's very, very important. Okay, so please, I hope you have understood this point. Okay, now all structures are removed in the radical neck dissection except the answer over here is a digastric muscle. Okay, so what is this particular radical neck dissection? So for example, let's say there is some oral malignancy, so lymph nodes of the neck can get enlarged, and if at all the lymph nodes of the neck get enlarged, what is going to happen? You have to perform a neck dissection. You have to perform a lymph node dissections of the neck. Okay, so that is what you need to understand over here. Now, what are the structures which are removed in the radical neck dissection? In the radical neck dissection, you remove the lymph node stations from 1 to 5. Along with this, you also remove what? You remove the what you call as an internal kind of like, okay, so you jugular vein, you remove the spinal accessory nerve, and you remove the sternocleidomastoid muscle. So sternocleidomastoid muscle, spinal accessory nerve, internal jugular vein, these are the things which are removed in the radical neck dissection. Okay, so answer over here is definitely digastric muscle. But the radical neck dissection has a lot of comorbidities. Okay, so radical neck dissection per se has a lot of comorbidities. So what we have come up with, the modified radical neck dissection, MRND. We have come up with MRND. So what is this particular MRND? MRND is of 3 types, 1, 2, and 3. What is MRND 1? In MRND 1, what you do? You preserve. What do you preserve? So MRND 1, you preserve the spinal accessory nerve. In the MRND type 2, you preserve the spinal accessory nerve plus the internal jugular vein. And in the MRND 2, 3, what you do? You preserve the spinal accessory nerve plus internal jugular vein plus the sternocleidomastoid muscle. Are you understanding my point? All the 3 structures are preserved in the MRND type 3, and in the MRND type 2, spinal accessory nerve, internal jugular vein is preserved. In the MRND type 1, only the spinal accessory nerve is preserved. So these are again very, very important, guys. You have to kind of understand that there's something which is called as a radical neck dissection, there's something which is called as a modified radical neck dissection, and these are the things which you have to kind of understand in these particular points. I hope you have done. Very, very important. Okay. Now, after the head injury, there is a biconvex lens-shaped hematoma on the CT scan. What is the characteristic? Now, if at all you do this particular question wrong, it's the end of the story. This is a very, very important question. Very simple question as well. So, what is this? This is what is an extradural hematoma. Okay. What is this? Extradural hematoma. So, these particular words, biconvex lens-shaped opacity on the CT, basically give you the diagnosis of an extradural hematoma. Okay. Now, why this particular EDH is formed? EDH is basically formed because there is an injury to the skull and there is a fracture of the pterion. What is the pterion? Pterion is the what you call as the thinnest part of the skull, and just below this particular pterion, what do you have? You have an artery which is called as a middle meningeal artery. So what do we have is a middle meningeal artery. And whenever there is a kind of injury to this particular middle meningeal artery, what is going to happen? There's going to be bleeding, and which is going to lead to this particular extradural hemorrhage formation. So that is what you need to appreciate and understand in this. Very, very important. Biconvex opacity, extradural hematoma. Now, the most kind of common malignancy of the head and neck in India, it is an oral cancer. Okay, oral cancer is the most common head and neck malignancy in India. Amongst the oral cancer, if I ask you which is the most common type, and if I ask you in India, it is going to be the buccal mucosa. Buccal mucosa. So that is what is the most common type of an oral cancer which occurs in India. But if at all we talk overall, okay, if at all we talk overall, then the answer is going to be here, what you call as overall, what is the most common type? It is a carcinoma of the tongue. Okay, so please try to understand, it is a carcinoma of the tongue, which is the overall most common type of an oral malignancy. Yeah, that's what you need to understand. India, it is the buccal mucosa. Overall, it is basically the carcinoma of the tongue. Okay, I hope you have understood this point. Now, there is a patient who underwent a surgery for an inguinal hernia 5 days before, and now the patient has come to you with the complaints of the fever. What is the most kind of probable cause? Now, we also saw one of the questions related to this, right? So, what is this? This is basically based on the causes of the post-op fever. Post-op fever. Okay, now let's kind of like, I'll just tell you what are the causes of the post-op fever depending on the day. Okay, depending on the day. So on the day 1 to 2, okay, on POD 1 to 2, post-operative day, POD is post-operative day 1 to 2, what is going to be the cause of the fever? It is usually what you call as a basal atelectasis. Basal atelectasis. It means that the lower parts of the lungs are not able to kind of expand in a proper manner, and the alveoli of the lower part of the lung has collapsed. So that is what is called as the basal atelectasis, leading to the lung infection. That is the most common cause of the fever on the post-operative day 1 to 2. Now, what about the POD? Let's say 2 to 4 or something like that. In this, what is the kind of a cause of the fever? Okay, so in the post-operative 2 or like 2 to 4, what is the cause of the fever? It is basically what you call as your yeah. So over here, there is a urinary tract infection. So this is, you can remember it by 5 W's. Okay, so 5 W's. What are these particular 5 W's? First is your wind. What do you understand by the wind? Wind means your basal atelectasis. Then what we have is the water. What do you understand by the water? Water basically means the urinary tract infection. Okay, so urinary tract infection. Then what we have, the third W is basically your wound. Okay, so what is this? Okay, so walking, wound, and wonder drugs. Okay, so third W is basically your walking. What do you understand by the walking? Walking basically means that the patients might suffer from deep venous thrombosis and the pulmonary thromboembolism. So post-operative day 5 is basically what you call as your deep venous thrombosis, which has led to your pulmonary embolism. So we saw one question, right? In this particular 15 questions only, we had one of the questions where we had diagnosed that there's a patient post-operative fever, swelling, and whatever edema in the legs. What was the diagnosis? It was a DVT. So yeah, that is what is called as a walking. Okay, walking. Then we have wound. Wound basically means wound infection. Okay, wound basically means wound infection. So this is post-operative 5 to 6. Okay, so let's assume that we have operated on any particular kind of site, we have given an incision, we have taken the stitches. Now that particular wound may get infected. So over here, what is happening after the hernia surgery, that particular wound has got infected, and this is what is referred to as your what you call as a wound infection. So what is this? This is what is your wound infection. And then finally, what we have is wonder drugs. Okay, so what we have is a wonder drugs. Okay, you understand my point? So this is basically a POD 7. Okay, so around after, like, if you have kind of ruled out all these particular things, it can be drugs. Okay, so drugs means like any particular medication which is basically leading to an increase in the temperature of this particular patient. Okay, so these are the important things which you need to understand. Causes of post-op fever can be remembered by the 5 W's. What are these particular 5 W's? Wind. Okay, so this is What I've written, this has to be wind. Okay, wind means basically kind of basal atelectasis, then water, walking, wound, and the wonder drugs. Okay, so I hope you have understood this particular point. So these are the important things which I had to cover in these particular 15 questions. I hope you gained something out of it. See you in the next one. Bye bye. Take care.